Okay, so thank you very much, Gabriella, for having me today. I hope it will become now a little bit more practical, a little bit more tangible, just by the fact that I am a medical doctor, pediatrician, infectious diseases specialist. So we addressed actually those issues a couple of years ago in the Prohibit project. So my task now is to talk about CFR, the Consolidated Framework for Implementation Research. Laura Demschroeder, when she started her manuscript, started with this quote: "To see far is one thing, going there is another." So what is the reported evidence in the literature? And we heard this morning that there was a time when everybody was convinced that if there is enough evidence, evidence will drive change. And in a way it does, but it does not at all to the extent we would like to have that happen. So what we know from the literature is this. So use a bundle, use a checklist, do surveillance, use technology, do whatever you would like, and there is this big, huge black box, and then you succeed and you have an outcome. We do often not know what is in this black box, and all we do here today is about this how. How do we do things? And when we think about how we do things, we heard now the presentations of two specialists in the field, social sciences. So the perceived challenge for IPC professionals today is not the lack of scientific evidence, but the lack of skills in how to apply this evidence in daily practice. And Celine is right. By the end of the day, we have to do something in daily practice. Unfortunately, in a way that at the core of implementation research is the social science notion that scientific evidence is not sufficient to promote change in organizations. And this unfortunately is not about the quote, but this unfortunately is that we need the knowledge of social sciences to drive change. And we are not social scientists, and that's the problem. So, which brings us to CFR. So what is CFR? CFR basically was a systematic review. It was intended to be an update of a systematic review done by Trish Greenhalgh years ago. And the idea was to look for all the different theories in implementation research until a saturation point. That means that they stopped when they had more all over the same information, the same theory of implementation research to come up with a meta-theory. Interestingly, though, is although it was not intended to be used practically, years ago, when we started the Prohibit project was a European framework program with 4 scientific work packages, and two of those scientific work packages were one randomized control trial to reduce catheter-associated bloodstream infections in Europe. And the other was a qualitative research which would accompany that quantitative prevention strategy. And we were a group from Geneva, and none of us was a social scientist. So we had to learn. We needed a crash course, and we had to learn. So what we did actually, we went to Ann Arbor, where Laura Demschroeder works, and this is how we discovered CFR. And as a surprise, basically, is that CFR, from a person like me, who is not a social scientist, offers sort of a roadmap of implementation. So I perceive CFR as a roadmap on implementation for non-social scientists. And what's interesting in CFR is that actually it is a simplification at one end, but it is not an oversimplification on the other end. And this is why, personally, I like this. So what are the 5 dimensions of CFR? So now let's get practical. I will guide you through all the 5 dimensions shortly. Of course, when you read the manuscript, it's much longer, and you have many more details in the manuscript. So I would really encourage you to download this manuscript by Laura and read it. So let's start with the intervention. So one dimension is the intervention. The intervention comes as a non-adapted version or an adapted version. So I do go into details later, just let me mention the 5 dimensions. Then there is the implementation process. Then there are the individuals working, let's say now we are all in infection prevention and control here, working in the hospital, so this is the obvious inner setting with the individuals. So the hospital, and then we have the outer setting. Everything that is around the hospital and that influences to some extent what happens in the hospital. So let's start with the interventions. I would like to drive you, to go with you across some of the concepts within those dimensions. So let's talk about source of intervention. So what are important elements or concepts leading or really important for this dimension? Source of intervention. First of all, perception of key stakeholders about whether the intervention is externally or internally developed. So I put perception in orange. And why did I put it in orange? Because it is not your idea, it's not your perception, but it is the perception of the people you would like to change their behavior. So you have to think about what is their perception about the source. Maybe you are convinced that it's the most obvious and evidence-based thing in the world, but if your nurses and doctors, they do not believe the same, you have to take that into account. So if we have the inner setting, the hospital, and the outer setting, so usually when it comes from, we have infection prevention and control, we have our trusted sources. Usually what's coming from the government is not perceived as very positive because we claim that they're only interested in money and reducing costs. What's coming from the management often is not perceived very positive either. So usually what we like to see, and this is why it's green, it's the grassroots approach. On the other hand, I can tell you, yes, it's true, grassroots approach are good, but they have to become an part of the organizational culture. They need to be rooted in the organizational structure because when they should become sustainable. Evidence, strength, and quality, also, again, perceived strength of evidence. The more sources of evidence used, the more likely innovations will be taken up. So that's we can say that. Evidence, strength, and quality, we heard, can drive change. However, it is still perceived. Sometimes we understand evidence as a given physical thing that is obvious, but sometimes for people, for doctors, for nurses, it's not that obvious. It's because they do not know about how evidence is generated. I think not even the scientific and medical community agrees on how evidence is generated. I mean, we can talk about evidence. I mean, sometimes we have one randomized control trial and we say, okay, case closed, and everybody changes practice. And sometimes we say, oh, it's only one randomized control trial. Let's wait for another randomized control trial, maybe after the 5th randomized control trial. So what I want to say, we are not free from culture and beliefs and perceptions. So evidence, yes, but the perceived evidence is not as straightforward as we think sometimes it is. Relative advantage, that's an important one, because when somebody should change their behavior, they should be convinced that this behavior change adds something to daily practice. It simplifies the process, it adds quality or whatever, but a relative advantage must be perceived. Otherwise, it is difficult to change practice. And again, strong scientific evidence is not a guarantee for perceived relative advantage. So there are other relative advantages which are rooted in the processes, rooted in the organization and in the organizational culture of the hospital. Adaptability is important. There is no way around it. There is a core, so here in orange, and the blue thing here. The blue thing here is the intervention, this is the hospital, and this is the core. And you cannot force the intervention to be taken up if you just force it to be implemented. I mean, forcing an implementation may work in the army, but usually it does not work in the hospital. The point is that you have to be clear about what you want to implement. For instance, you want to provide alcohol-based hand rub to healthcare workers in the hospital. So this is your idea. But then there is a fuzzy periphery about it. And then you have to think about how are you going to do this? Do you use dispensers? Do you put them on the bed? Do you put them on the wall? Do you use bottles? What do you use in pediatrics? What do you do in psychiatry? What do you do in a Muslim country, for instance, where alcohol is an issue? There are all sorts of things that you have to consider before you start planning your intervention. Trialability usually is helpful. So if you can start slow, we heard about it, pilots. When you do an intervention and you can test it, dry run it in your hospital, that helps you first of all for yourself, and also you can prove maybe to your colleagues, peers in the hospital that this can work, because you showed that you did it and you adapted it, and then you roll it out in your whole hospital. Complexity. Keep it as simple as possible and as multimodal as possible, but keep it simple as possible. And again, this is the perceived difficulty of the intervention. So it does not help if you think this is the most simple thing in the world to do, if your nurses and doctors have not the same idea of that, and they think, oh my goodness, this really makes my work complicated in daily practice, then you're lost. And then you have to just reconsider. Break it up. For instance, in Geneva and in Zurich, where I worked before, we had complex behavioral change interventions, and we always stratified them. It always came in modules, and we always did one thing after another. Then design, quality, and packaging. Yes, I think it matters. I mean, if it's nice, if you love the product, if it's delivered in an ergonomic, pleasing fashion way, I mean it's appealing, then I think people will just love it, and that it's just easier to adopt. I mean, we are human beings, and we like nice things. If something ugly or a presentation is not. I mean, we are appalled by a presentation, then we just a priori we don't adopt it. It's as simple as it. We are human beings. We function like this. We cannot do otherwise. Costs. Yes, costs is an issue. Interestingly, is that our colleagues at the front line, nurses and doctors, they are aware of costs more and more. And it has become part of our thinking, not only among politicians, managers, but also in the heads of everybody. So I think we can talk about this, and resources just need to be taken into account. Let's move to implementation process. So how do we do it? This is the project management, so to speak. So we heard about this already this morning: planning, engaging, executing, evaluating. The 4 process activities are not meant to be sequential. But what should we do? I mean, I like this one because the process could be let it happen. So we just don't do anything, and we just wait until things fall into place or not. Or make it happen, managerial or even army-like. And I would say that we are, in a way, here, help it happen. It could be, then it depends on your hospital, whether you are more here or you are more there. You say here, social, technical. I think we oscillate between this. And usually when you look at successful implementation strategies or clinical studies, you can see that often it's a combination of both. For instance, also in Geneva, when we did our prevention strategy for catheter-associated bloodstream infections, we were very strong on how we trained doctors and how we trained nurses, but it also came along with a change of materials and ergonomics. And I think you should really go on both tracks, or move on both tracks. So planning is a degree to which a scheme or a method of behavior and tasks for implementing an intervention are developed. So the most important, I think, is planning takes time. So be serious about planning. Don't rush into something. Take your time. It's better to wait another year, and have a good project than just rushing into project and it's a disaster. Because if it does not work due to shortcomings in planning and managing, you will lose many other years. Engaging, so have the right people in the right seats. So when you do something, be clear on who are the stakeholders you would like to have on board. It's better to have people on board you know they do the work than having somebody on board that you just have to have on board for political reasons. I don't know the situation in France, maybe in England, maybe you can choose. But in other countries, for instance, where hierarchies are very steep, sometimes you are obliged to have this particular person on board because otherwise it would not run. And sometimes it also makes sense. I mean, if you have a study, if for instance you would like to have a project rolled out in a hospital, and you know that the departments are functioning in silos. I mean, having a representative of each of those silos in your study group is great, and you should go there because otherwise you can roll out your hospital-wide program everywhere except in the surgery department just because you don't have anybody from the surgery department in your study group and they are not interested in your work anyway. Executing, again, dry run simulations, pilots, and break down complex interventions to manageable parts. I think those are the main approaches. Evaluating, I think you should always evaluate, not only at the end of your project, but this should be an ongoing process. And don't be afraid to adapt your intervention when you see some problems, some challenges, some barriers coming along. Individuals, and I would like to take your time to read this. So my quote, people are not potato bags. So we are individuals. We have our background, our culture, our history, our past, our whatever. And this is just a fact. We cannot make our colleagues, stakeholders, potato bags. So we have to live with their identities, their individual lifestyles and attitudes. So when we think about an organization and the performance of an organization, what we are really thinking of that determines on different factors outside, we are really thinking on people forming the organization and people delivering performance. In a hospital, it's people delivering performance. We do not have machines delivering the performance. So we have to just live with the different individuals, with their different state of knowledge, with their different beliefs, with the different self-efficacies and perception of their self-efficacies, the different state of change, young, old, more experienced, less experienced, whatever, and their attitude towards the organization, which I find quite interesting. So let's go through quickly knowledge and beliefs, the individual's attitudes toward the intervention and familiarity with facts, truth, and principles related to your project, the skill levels, and again, if you detect a lack of skill levels, then you train, you educate. But if everything is okay, then you use your resources to invest in something else, as we heard also this morning. Subjective opinions from peers are readily accessible, and these opinions help to generate enthusiasm. That means we all look around us, and we all have people we trust more and people we trust less. We all depend on the opinions of peers. So that is just a fact. Your role is to use this and try that to find peers, champions that can take, that they are credible role models and they help you to make your project. Self-efficacy capabilities. I'm always puzzled that in our hospitals we seem to believe that everything is perfect. And everything that is less than perfect is not good. But basically we just black it out. So we live in a perfect world in hospitals. When you talk to your manager, your surgeon, to your internal medical doctor, we live in a perfect world. And nobody really asks about if we are capable of what we are doing. And sometimes it makes sense to also look at that. Not only that, because we like shortcuts. I mean, we do. That's, if as human beings we would not shortcut in our lives, life would be unbearable. And this is part of aging process. I mean, when you're a child, you don't shortcut. And when you're aged, I mean, you shortcut all the time. Even in your thinking. I mean, you can listening to somebody and not even really hearing what's being said, because you are already a keyword that brings your thoughts to another, to something else. That is maybe even important for you because you know in 10 minutes you take the bus to go to the airport, for instance. Things like this. We function like this. This is normal. Individual stage of change. We have to take into account where people are. And I think it is good then when we adjust our intervention, that we take that into account. What is the standard I want to go, and where do I have to start my intervention? What are the messages I have to deliver? What is the minimal standard that is already there? Attitude towards the organization, I find that quite interesting because we also experienced this a lot during the Prohibit project. That identification with the organization really makes a difference. I still recall a hospital in Dublin. They wanted to be the best. But who does not want to be the best? But what was really different in that hospital is that in the Prohibit project we did interviews. And we always interviewed the CEO, the medical director, the nursing director, the head of the ICU, head nurse of the ICU, the entire IPC team, and also frontline workers, frontline nurses, frontline physicians. And at the first round, when we went there twice, always before the intervention and 1 year into the intervention. And the first round, we basically sat there, we had our very, very open questions, and we tried not to interfere with the people. And what happened is that independently, everybody we interviewed told us how great they are, how proud they are, that they know that they are the best in the region and they really want to do that, and how blessed they are because they are so good, they can hire the best, and so on and so on. So you could feel that this attitude was deeply rooted in the organization, and they performed well, and they were really good. So this is interesting. And there are other organizations. We had also other organizations. Everybody was complaining. I think after we left the hospital, we knew more secrets about the hospital than people working in the hospital would know. But anyway, inner setting, structural characteristics versus social architecture. This is just, we understand the clustering of people within different groups and the coordination of those groups. Networks, we have to think about what are the inter-organizational networks and communication, because there are networks. And usually I mentioned silos, yeah, this is what we often see. But sometimes there are networks across the silos. When we talk about boundary spanners, we also saw that. When you have people that move across those silos and they know different people in the silos and you are very skillful in communicating with those people, they can be very helpful in your project. And indeed, we had a couple of hospitals in Prohibit who really lived on those boundary spanners, and they perform quite well. Communication is important. We can distinguish formal structure, informal structure, channels of communication. Basically, the more skilled, the more elaborate your communication is in your hospital, the better it is generally for quality anyway, but it also can help you to implement your project. Then the organizational culture. The organizational culture is a difficult thing. Basically, it's norms, values, and basic assumptions, okay? We also know that culture is stable, but also that culture is subconscious. So when I ask you, what is the culture in your hospital? I know that now different things flashed to your heads, and everybody had an idea. But when I'd ask you, okay, tell me what, in your words, express what is the culture in a hospital, and then you would say, but in your brain, in your head, it's crystal clear what's the culture in your hospital, and you have to take that into account. So usually, what we say that the easiest way to define culture is the way we do things around here. So this you cannot get simpler than that. So we have the receptive context and absorptive capacity, implementation climate. What do we understand? We have the tension for change. So the degree to which stakeholders perceive the current situation as intolerable. So if they agree that change is needed because you had an outbreak, because you had a patient dying, because you had the press in your hospital, or whatever. I mean, usually this is quite nice drivers. And as Andreas Voss always says, never go an outbreak go to waste. So use them. I mean, you don't want them, but if you have them, okay, use them. Compatibility, intervention, context fit, which I just talked about this before. So adapt your intervention to your context. Relative priority. Also, it had perceived an advantage, but also relative priority. Another Prohibit example. In one of the Western European hospitals, university affiliated, Prohibit was one of, 20 projects going on in the intensive care unit. And when we went back there after a year, there were people, they did not even know that Prohibit, do we have this project here? And you can imagine there was no change in that hospital. While in Eastern European hospitals, Prohibit was the one intervention, European. They were proud of having this intervention. So make your intervention a relative priority, high up in the priority list of your hospital. Otherwise, it becomes difficult. Incentives, yes, use incentives. Incentives are not always monetary, but they can be also psychological, social, and play with this. Learning climate. So this is, does your hospital encourage healthcare workers to learn? Does it provide a safe environment to learn? That means you can accept failure. But of course, we do not want to accept too many failures in our hospitals because we still care for patients. So we have to work at the safe environment. So we have to find ways on where we can practice, we can learn. For instance, in simulator training, on dummies, whatever, that we can really practice and progress. The other one of the receptive contexts, absorptive capacity, is readiness for implementation, leadership engagement, yes, of course. Commitment, involvement, and accountability is important. However, lip service is the worst that can happen. Anything less than wholehearted support from leaders doomed implementation to failure. So if you ally with the manager that shows up spot on, we support this project, and then disappears and was never heard of, then it's bad for the project and maybe also for your reputation. Available resources, that's key. You need to have sufficient resources. Underfunding is one of the elements or the factors which drives implementation or projects, or which let fail projects. So you need to be clear about what you need in terms of time, material, location to train, maybe hardware, whatever, but you need to list that. I mean, in the Geneva project in CLAPSI prevention, we also had phases where we had underfunding. And this was one of the shortcomings we had. I mean, we lived a little bit from hand in the mouth, I would say, in German, so we really did not think too much about this. And we were at some stages about to let go of the project because we did not have enough money. Access to information and knowledge. This is easy to access to digestible information and knowledge about intervention, how to incorporate it into work tasks. So make your project known, and try to also go with your. So there's a difference where the information comes to the stakeholders, or the stakeholders can look for the information. So usually give them information. Simple, easy to understand information. Outdoor setting, I do not want to say a lot, because it's a very complex dimension. Basically everything that is around your hospital, also you have the culture of your country, and external strategies to spread interventions, policies, regulations, recommendations, guidelines, and so on. What's interesting, though, is that also the politicians, they have a role in implementation, even if they do not know that. But if decisions back quality decisions in your hospitals that help you to do or to implement best practice in your hospital, when you can say, okay, this is just something we have to do because health authorities say that, then it helps you, even if it's maybe not very comfortable, but it helps you. Also, if recommendations define responsibilities, this also can help you. If they say this is the hospital manager is responsible for the quality, is responsible for the outcome of the patients, is responsible to run a functional infection prevention and control, this helps you. Cosmopolitanism, this is the degree a hospital is networked with other organizations. This is more like an innovation thing. When your hospital networks with another hospital, let's say you have a joint agreement with Johns Hopkins or Imperial College or Ann Arbor, that shows that your hospital is willing to adopt innovation. And this degree of cosmopolitanism helps you because it also shapes the organizational culture and the receptiveness in your organization for new things. And this helps, because if you work in a hospital that is networked to that degree and sees leaders in the field as their peers, they will be more open to say, okay, yes, let's do this, because you want to be at the forefront of everything. And peer pressure, we also heard about this. This happens anyway. I mean, it happens in a positive way and it happens in a negative way. And we just have to make sure that we use peer pressure in a positive way. Then also, last but not least, strong focus on the customer. I think if the hospital, sometimes we forget about who we are working for. I mean, hospitals would be such nice places with our patients, and we would be much more comfortable. And but unfortunately, we do have them, and we do even have to care for them. But I think if you have a strong focus on the customer and you don't forget about why you are there, I think this also can help you to move forward. In summary, and this is my personal view on things, I think that IPC professionals should be empowered in the organization. I will talk about more this afternoon. You need to think about infrastructure, equipment, resources before you start something. You need to establish some sort of surveillance, audits, feedback to know what's going on, and also to feedback to your healthcare workers before you start an intervention. And then you start the intervention, low level, first intervention. And then you reach your stakeholders, healthcare workers. You reevaluate. You do the second intervention, more people. Third, you reevaluate. Third intervention, and so on, and so on, and so on. So, bits and pieces. One thing after the other. One thing, reevaluation. Other thing, reevaluation. In hospitals, we have a lot of turnover. And what I wanted to exemplify here is the oranges are the ones staying, and the black ones are the ones leaving. So when you understand your implementation or your project as being something that's going on and not something that is a one-time shot, you change culture, the way we do things around here, to the new way we do things around here, which is rooted in the people staying in your hospital. So if you do things over and over during a long time and be inventive, don't be boring, then you will create your core group. And this core group in orange changes. And because you heard culture is stable, you can really change culture, and once you change the organizational culture, it will stay. And with this, I would like to thank you for your attention.
Thank you, Walter. Some questions ou des questions dans l'audience. Alors, je suis arrivé en retard, c'est pour ça que elle m'a vu. C'est bizarre parce que elle ne m'a pas vu. Bon, enfin, voilà.
Il est pas assez grand.
Thank you very much for your really nice talk. I find it striking in your intervention that all the process is very empathic for people you work with. And I think I have a part of the answer. I think that this is what really works. But if I give you another example, extra-medical example, the government lowered the speed limitation at 80 kilometers on small roads. And apparently, within a few months, the death rate on the roads lowered very significantly. Can you give us a comment about coercion in medical processes?
Well, you know, what I can tell you that when I started to be interested in implementation, we came across this diffusion of innovation, Rogers. This is probably everybody starts there. And I realized at some point that actually it doesn't really apply to our field, because what we promote in the hospitals, it's not something that people were waiting for all along and for years. But actually we try to change behavior for something that try to avoid as long as they are living. And indeed, we have to find ways on how we can encourage them. I heard in France the government enforced the compliance with 80 kilometers per hour by applying many radars, which were not seen anymore. Before you had all those panels that would announce, "Take care, there's a radar." So I think it is a little bit. You need hard edges and you need soft interventions. I think there is always a little bit the same of that. So you have to probably this is where you need the managers. I think probably you need to set the level. You have to agree that okay, so we won't go there. And if the hospital says yes, okay, this is our level we want to go. This helps you. So this is the hard edge. And then you do audits. But audits, personally, I understand audits are something that is an intervention, that it's not just an observation or surveillance strategy, but it also helps you to shape the change of behavior. And then I think you should work on champions, you're having peers, and basically it's very much this. So probably if we just keep working on, and you have one intervention could be ex-cathedra teaching, another then is hands-on teaching, another is an event, another is a party. I don't know. I mean, in the Michigan project years ago, Pronovost, I will talk about this afternoon. They used workshops, and there were the cocktail parties, and I mean, I don't say that those were responsible for the overall success, but I think they played a role because this then changed the culture, and I think you have to go there. I cannot be more specific than that. And again, there is no cookbook, but I think so. This is why I talked about CIFR. I think when you think about an intervention, what you are going to do, so those dimensions give you a map, and then you have to listen. You have to know your institution, and then there's no way around just thinking about, okay, what do I need? So where do I expect barriers? And then if you expect barriers, just ask. So don't assume. So for instance, when you think the head of the surgical department does not support you, go there, make an appointment, and talk to this person, because sometimes you may be wrong with your assumptions.
Walter, one question. When you started, you showed us a black box. I'm not sure it's being transparent at the end, except for the last slide. It was very, very clear and significant. So my question is about the workload and time frame for implementing this type of intervention. So you talk about Prohibit, which was a several-year program. But in your hospital, with all the duties we have in infection prevention and control, how can we start very simply, and what is the workload and time frame? Can you?
Yeah. I think, I mean, there's a tendency that we are overloaded with things, because, I mean, first of all, we have the daily work. I mean, all the nitty-gritty and the questions which need to be addressed in daily practice. And I think, and then there is a lot of surveillance going on in post by governments usually, and this binds a lot of workforce. So my personal view on this is that we need to have time for the daily work, the nitty-gritty work, and then we need to do some surveillance. But I think in the future we should try to make this electronically. I think there is no way around this. And then we need to think about what project we would like to implement. And we cannot implement everything. Of course, we would like to have everything at once, but this is impossible. So my advice is that when you see a problem in catheters, start with a catheter, then move to urinary catheter, then move to pneumonia, and then come back to catheters. And this also, by the way, makes it more interesting for your colleagues. I can tell you, Geneva and hand hygiene. I mean, there were times where the words hand hygiene fatigue. I mean, people were just fed up about hand hygiene. They could not hear that, could not stand that anymore. And then this is so it's better now after a break. But you need some breaks. I mean, you have to you know. I mean, we are human beings. We need to be entertained in a way, and you can use that.
Thanks a lot, Walter. Very, very nice presentation.